Hello, good morning. This is new programs today. We had a very special guest, Dr. Holloway. Dr. Holloway is a professor and chair of the Department of Neurology at the University of Rochester. His background, basically, he received an undergrad medical degrees at the University of Connecticut, and he has his training in neurology in an MPH at the University of Rochester. He has been a faculty at the University of Rochester since 1993. He has been a chair since 2013. Dr. Holloway is boarded in neurology and palliative medicine. He has a very active research interests, very broad, including experimental therapeutics and outcome research covering many areas of neurology. He has authored like over 175 manuscripts, reviews, editorials, and he has been co-editor of 3 books. They are case studies in neuroscience, primer on palliative care, and neuropalliative care. And he has also received many awards. So I just want to welcome Dr. Holloway. Thank you for accepting our invitation, and you have the spotlight right now.
Great, thank you. Can you see my screen?
Yes.
Great. Well, Blake, thank you very much, Sergio. And I'm just honored to be here with my fellow New Yorkers from downstate. It is very snowy right now up here in upstate, and but it's a typical day in Rochester. We're still behind our snowfall counts, but we're catching up after certainly the last couple days. Well, welcome. I'm thrilled to talk to you about a topic that you probably don't hear too much about, and that's kind of prognosis in neurologic disease. And the irony for me is actually every visit that we probably have always involves a prediction, but we don't actually often hear too much discussed about it. So I've tried to put some of my thoughts down and share some of my thoughts and some of the things that go into prognosis, and can we be better at it as clinicians, and can we study it as researchers? As Sergio mentioned, I have several grants, none of which conflict with this talk. I am boarded in hospice and palliative medicine, and I adapted this talk from a module that actually is in a set of modules from the Education in Palliative and End-of-Life Care Neurology, or the EPIC-N series of modules that exists within the International Neuropalliative Care Society, which is a new society that was just formed last year. But they're free to anyone who wants to use them. And there's 18 modules now. This is one of them, which I adapted, but there's many others. So for training programs to kind of spread the word for neuropalliative care and how we can teach and train palliative care physicians more neurology and more neurologists palliative care, it's a very good set to start from. So we all probably have prognostic mishaps. And certainly I have over the years. I remember them vividly, and I'll never forget them. Some of the errors I've made in terms of prognosis, some of the biggest surprises in my clinical practice in medicine that I've ever had. For example, I remember one patient who had a large intracerebral hemorrhage, and I was very pessimistic in my kind of outcome predictions with the patient and the family. And kind of despite my pessimistic outcome predictions, they decided to kind of pursue full care. And 6 months later, I saw them in follow-up in my clinic, and not only with a very severe left hemiparesis, but not only did they recover well with a cane and with some functional disability, I'll never forget her saying to me that this stroke was the best thing that ever happened to them, because now I don't have the anxiety that I had prior to my stroke. And it just certainly, I learned that my prognostic predictions probably wasn't as well informed as it could have been. And I have many more up through even last year where I have had predictions of prognosis that have been in error. And I try to self-reflect on them in terms of what have I done wrong or what I can do better in those times. And these are a few quotes that actually are about prognosis. The practice of medicine is like wine, and prognosis is the dregs. Or another one, patients and families will forgive you for a wrong diagnosis, but will rarely forgive you for a wrong prognosis. And I think we all kind of feel that actually when we think about diagnosis, therapy, and prognosis. It has not received much attention in the literature. These are two actually books that have been written. Death Foretold, which was actually published in 1999. You may recognize the name Nicholas Christakis. He's now a social anthropologist at Yale and is actually in the news quite frequently. But he was a former physician and actually a palliative care physician. And he wrote actually this book back in 1999. And then many of you may have seen the Super Forecasting, the Art and Science of Prediction by Phil Tetlock, a cognitive psychologist, published in 2015, where he actually holds super forecasting tournaments for the federal government to kind of identify what makes a super forecaster and actually develop criteria about those individuals who actually can predict better than others, even experts in their fields. And this is Bill Flack. So Bill Flack is a super forecaster. He actually is not an expert in geopolitics, what he was trying to predict, but he actually was about 30 to 40% better than the experts in the CIA in predicting geopolitical events. And Phil Tetlock in his book describes what were the characteristics of Bill Flack and other super forecasters that could actually make those predictions. And he not necessarily is a geopolitical expert. So this kind of begs the question, there's probably medical experts who have expertise in their own field, but may not actually have the skills that could make them experts in prediction. And what are those kinds of skills that allow one to do that in the medical realm? So these are my learning objectives: to understand the importance of and barriers to prognosticating in clinical practice, to reinforce skills to become a master prognostician, and to develop radical awareness of some of the common biases that may interfere with your prognostic communications, and then to understand and manage prognostic discordance when it occurs with patients and families. I just want to mention that there are many other modules in EPIC and neurology. This is the one here in prognosticating and neurologic illness, but there are 18 others across, and you can go to the website, INPCS, and you can download these. They have notes and they have descriptions, and they're very well done. And I encourage you to take a look at them for these various topics. So everyone deserves a palliative approach. And, if I had a vision, I think we all do, is that all patients and families are treated with the highest quality of care and have the best palliative approach that we can provide them, providing a diagnosis with skill and compassion, addressing their emotional and spiritual concerns, providing anticipatory guidance and advanced care planning, addressing non-motor symptoms, and supporting their family. And I highlight here providing anticipatory guidance, because this is where kind of the prognostication and looking toward the future and informing them of what is to be becomes central to all we do. And as I said in my first comment, that I think every visit we have involves at least one prediction and probably many others. And even Hippocrates mentioned this millennia ago, and he said, translated by J. Chadwick and W. Mann, "It seems to be highly desirable that a physician should pay much attention to prognosis. If he is able to tell his patients when he visits them not only about their past and present symptoms, but also to tell them what is going to happen, as well as to fill in the details they have omitted, he will increase his reputation as a medical practitioner, and people will have no qualms of putting themselves under their care." And still so true today. I won't belittle this. We all kind of can look up definitions of prognostication. Sir, I put this down in print a couple, 2014 in neurology, and something I wrote called The Process of Estimating and Communicating, quote, what to expect for an individual's disease course. And then here's just the definition from Cambridge: the act of making a judgment about what is likely to happen in the future. And we all know that prognosis in neurologic disease is paramount, probably as much, if not more, than many other disciplines, quite honestly, partly because we have such burdensome outcomes. And these burdensome outcomes are considered actually as bad or worse than death in many circumstances. And one example was just published last year by actually a faculty now at Wash U, Elise Everett, where they just interviewed patients who were admitted to the hospital with stroke about future health states, and were they much better, somewhat better, little, neither, or worse than death. And you can see here the color-coded bar graph that shows that many of the neurologic outcomes that we sometimes have to navigate and negotiate with families and patients are viewed as worse or neither, better or worse than death. So our outcomes are serious, they demand our utmost attention, and they are central to our goals of care conversations. And in addition to just the outcome and the severity, there's a high variability and complexity in prognostic predictions. And as one War General said, applicable to medicine as well, it is impossible to lay down binding rules because no cases will never be exactly the same. We often have to depend on surrogate decision makers. And obviously prognosis is absolutely central to shared decision making, many of them leading to life-death decisions. And really prognosis drives the therapy decisions and really becomes the most powerful, in fact, powerful drug or procedure in your toolkit. We all know this, we all feel it when we get nervous having these kind of high stakes conversations with patients and families. What do our patients and families need? Certainly high levels of need for information in all stages of the illness across multiple domains, including prognosis. As the disease progresses, caregivers tend to want more information, while patients often tend to want less, but that can be variable. And surrogates often feel overwhelmed and poorly prepared to make choices on behalf of their patients. This just shows a kind of a triangular diagram of the medical procedure we call shared decision-making, where we have the medical situation, we communicate a prognosis from left to right. We actually explore values and preferences with our patients, so we develop a plan, and we actually have our outcomes, whether it's withholding, continuing, aggressive versus palliative, assist with hospice determination. And prognosis can be, it's called the 5 Ds, one of these dimensions. But how do we prognosticate most effectively to actually ensure that our decision-making and plan is goal concordant, as close as it can be with the patient and family's values and preferences? The consequences of the errors are huge. If we're overly optimistic, actually, we may lead to errors of overuse, where you can have poor symptom control, unnecessary tests and procedures, delays into hospice, and false expectations. So optimistic predictions of prognosis have their consequences. Actually, pessimistic subsequently have their consequences of underuse of life-sustaining treatments, resulting in premature death, missed opportunities for treatment, failure to explore adaptation that occurs with neurological health states, and certainly regret and grief. This just shows a study that was published by Ben George, who now is here in Rochester, and David Wong, who's an associate professor at Yale in the neurocritical care unit, looking at a very simple question. If you actually look at what's the probability of all patients in the United States admitted to the hospital with a stroke, what's the probability of coming out with a feeding tube? That's all the question is. And this shows that after you adjust for all those patient and hospital characteristics that could be related to patient characteristics of a stroke, there's this huge variability that actually arises on what's your chance of getting inserted a PEG tube if you come into a hospital, all ranging from 0 to 26%. Kind of pointing out that this process of shared decision-making, which negotiating whether a PEG tube will be used, which is a very preference-sensitive decision, is really messy. And there are hospitals and kind of teams who actually put in them all the time, or up to 1/3% of the time. And there are actually teams, hospitals, and regions that do it much less frequently, doing it nearly never. And so that shared decision, but that probably has elements of the variability of actually how people negotiate that very sacrosanct shared decision-making process. And it questions is that variation too much? And how do we actually account for that? And there are very many barriers to addressing communication in prognosis. There's just a cognitive dissonance in actually thinking about the future and death and bad outcomes. We all have it, and we kind of have to fight to overcome it. There's just huge amounts of prognostic uncertainty, which we don't like. We like seamless things that make sense, and we have to kind of confront that. There's a lack of training and expertise in this, which the modules in your training programs, I'm sure, are addressing and breaking bad news and discomfort and build confidence. And just like Phil Tetlock in his super forecasting experiments, you can train people to do better at this. There are simple techniques to actually do better. And there's fear of destroying hope, but sometimes, so how to navigate kind of the multiple hopes that we have with our patients, and also just not enough time. But there are these ways to address this that we all are kind of thinking about when we're thinking about delivering and communicating a prognostic estimate. This was John Keats, one of my favorite, actually, poets and physicians in English literature, when he once said, "At once it struck me what quality went to form a man of achievement when a man is capable of being in uncertainties, mysteries, doubts, without any irritable reach after facts or fiction." Kind of speaking to the emotional intelligence it takes to think about the information and consider prognostic estimates when stakes are high and emotions run high as well. And so what is the kind of palliative care approach to actually thinking about prognosis? And I put this there as nothing more I can do with a big X through it, because it just breaks my heart every time I hear that term. And you still do regarding patients and families. And it just breaks my heart when I hear it, because there's always something more we can do in our field, even when we may not be able to deliver, and we pivot into different goals of care. So what are these mindset, skill set, and tool sets that one has to have when thinking about prognosis? This is kind of aspects of the mindset. It's changing the way we pay attention and becoming familiar with and listening for prognostic triggers. I certainly have become more attentive to things when I'm working with patients and families on certain things that arise during the course of their illness, like, for example, weight loss, eating habits, things that I never used to listen to regarding prognostic triggers. Having the courage to fight that cognitive dissonance, to talk about difficult realities, and helping patients and families co-create an honest roadmap for the future, and kind of walking that walk together with them over time. And then they shift to this acknowledgement and acceptance that uncertainty is essential for us as providers, for our patients, and for our healthcare system as a whole. And actually, again, being able to kind of tolerate that ambiguity, which is both needed in medicine and both needed in leadership. And so when listening for prognostic triggers, it doesn't have to be actually at the end of even life, near the end, but it can be at the time of diagnosis or at multiple time points during the course of the illness. So pay attention in ways that we hadn't, and thinking about prognosis and prognostic estimates and having conversations about the future in ways that we may not have in the past. And the timing of prognostic, as I said, it is dynamic. You have to reformulate and rediscuss. I said at the time of diagnosis, routine intervals. You have to always explore whether the patients and families want to talk about it at routine intervals, at certain health events, actually, and certainly Parkinson's or dementia care. There are certain health events that may trigger a possible need to just explore it, and then changes in clinical status that change the prognosis or require new decision-making. Certainly in the cancer world, metastases or other changes in response to therapy may be triggers for initiating conversations, but it may be other times, certainly in our diseases. And we just need to recognize that the vast majority of patients and families want this information, even though they kind of crave it and fear it at the same time. And we often wait for patients and families to ask, but I think there can be a balance here, being a bit more proactive at times and thinking about this and supporting them through that. And this is another, just quote, "The dynamic nature of prognosis can help balance the inherent uncertainty, but if physicians are already reluctant to prognosticate one time, it may be difficult to convince many to prognosticate on a more frequent basis, recognizing some of the challenges we face in confronting difficult news." And then the tools, tips and tricks, the tool set is understand the basics of risk communication, possess a working knowledge of meaningful outcomes within your field of expertise, and actually That's all in your subspecialty areas. You all know them. Palliative care physicians are kind of nerdy in a way of collecting these kind of words and phrases that kind of help with our discussions to make it easier. But they do help. And, I've had to practice these all through the years, saying such things as I don't know. It's hard to predict in any given individual, but when people are actually nearing the end of life, I actually prognosticate using hours to days, days to weeks, weeks to months, or months to years, those frames to actually convey the distribution of uncertainty. And other things like it can be longer and we'll do our best, but it also could be shorter, so we'll be prepared. So these phrases that can sometimes help just reduce the barriers for having these discussions. And then obviously the hope for the best to prepare for the worst. And then judicious use of time-limited trials, which I'll just have a slide in a minute on. I won't go through here the basics of risk communication. There's some really nice data that actually, this is adapted from Fragerlin article in 2011. I think it was in the Archives of Internal Medicine. Just going through some of the things that most people can aid them in understanding risk and information. Obviously, using data, using frequencies, 1 in 100 versus 1%. Percent data using absolute rather than relative risks, which can magnify the impact, either negative or positive. Negative and positive framing can affect, and so you often use both to balance both sides of that equation. And you often present most critical information even at the expense of completeness, and express the time interval over which the risk occurs. And actually, those of you on stroke services probably do this very well when you're talking about adding an antiplatelet or therapies and thinking about the risk reduction over what time period and what is that absolute risk reduction expressed as a frequency rather than a percent. Or you could, do both, but that's in general. And then the time limited trial, I use these all the time. I wrote something on this several years back now on their use at the end of life. That can just help with many things, because actually a way to address uncertainty with patients and families when you're a little uncertain, it's just a time limited. We'll get back in a week and we address at that point. We'll have a little bit more information and we'll calibrate where we're at, including the prognosis, including the response to treatment, and we'll rediscuss the goals of care. It also just allows patients and families the time they need to come to grips and to build trust and reevaluate goals. So what is this skill set, this kind of super forecaster set of skills and mindsets? Well, you have to develop and practice skills to formulate a prediction. And I separate actually prognostication into two things: formulating a prediction and then communicating what to expect. Those two things are distinct activities. And then to be aware of common biases that may interfere with your estimates, your prognostic communication, and understanding and managing prognostic discordance. So we'll go through each of these. And this is just an overview of those two distinct aspects of actually super forecasting. That's formulating a prediction, communicating what to expect. And I'll deal with these separately, just because they are two separate activities that do blend into one. As you can see here, the formula, we'll start with the formulating prediction. I just have this circular kind of a set of activities causing anticipate, anchor, tailor, and debias. I'll say it again: anticipate, anchor, tailor, debias. And then we'll move on to what to expect. So just, again, most of you know this intuitively, and I don't mean to be so kind of basic, but obviously, what information will the patient and family want? Do your homework, think through the two simple questions while you anticipate: how long and how well. How long is just most relevant in terminal stages, needed for hospice and termination, and at least the United States, that's two physicians who agree that the prognosis is going to be 6 months or less. Those criteria, I think, are outdated and need to be updated, but they still exist and you can find them. And certainly your hospice and palliative care colleagues know them. And then the surprise question, that actually subjective gestalt, that actually you feel that the prognosis may be 1 year or less, or 6 months or less. And then how well, envisioning the roadmap and helping patients live as well until they die. And in many cases, that's actually more relevant in neurologic disease, because of how well they will function is what, what's the future health going to be like? How do you describe it? And then how do you anchor? Phil Tetlock in his book, Super Forecasters, calls this the external view. And super forecasters actually do this almost by habit. They always find the external view or the comparison class on which to anchor their predictions. And I actually argue we should start with survival data or typical disease trajectories just to start getting used to us, to cultivate prognostic awareness, which we don't often think about. You know, here I put up a growth curve. We often think about this curve, and we all kind of inherently know what this curve is, and but we don't think about the curve at the opposite end of life that often. And I think developing prognostic awareness and thinking about those curves can help. And then finding that comparison class. How do you anchor your estimate and start somewhere, and then you can individualize it further? Super forecasters do that. They always try to find the comparison class in there, whatever geopolitical prediction is, whether it's, you know, it could be any kind of number of series of events. And then prognostic indices or web-based tools, another way to find the comparison class, that external view, before you start on the internal view of your own patient. So that's anchoring. This is just a, actually, I bet probably you don't even, I actually have cut this out and laminate this and put it in my front pocket when I do palliative care rounds. This is just a life table of actually survival or life expectancy of various groups, ethnic groups, and actually you can have it done by race, gender, and ethnicity of life expectancy if you reach to the following age. So when I'm rounding on patients, I will actually pull out this laminated card just as a way of starting to get people to start thinking about just what is, if you're seeing someone who's 94 years old who comes in with a stroke, you know, what's the comparison class of someone who's healthy, 94, and what's their average life expectancy? We don't often think about that, and you'll be surprised, actually. Some of these life expectancies are higher than you think. So someone, if they live to 100, they have a life expectancy without a stroke of 2 years. And then you can start adjusting it based on the individual characteristics. So you find that comparison class, and then you adjust it to your individual characteristics. These are the 4 disease trajectories that have been described in palliative care. We all are familiar with them intuitively. The short period of decline, that's usually cancer with metastatic disease. And our diseases, it's ALS, CJD, glios, prolonged dwindling trajectory, that's function over time. That could be dementia, PD, and other neurodegenerative conditions, a swelling group. And then the chronic illness with exacerbation trajectory, multiple sclerosis, epilepsy within our field, but that could be CHF, COPD, end-stage liver disease, where you have these bouts of decreases in functions and then, you know, increases back, but not to the baseline. And at what point does that trigger a prognostic discussion? You know, we often usually say if someone's in the hospital 2 or 3 times over a 6-month period, boy, something's going on, and you probably need to think broader about their prognosis and their health and their comorbidities and diseases and where they're at as well. And then the severe acute brain injury with Claire Kreutzfeldt and I wrote back several years ago, defining the 4th trajectory, which wasn't well described, which is the severe acute brain injury trajectory, where you have this acute decline and this period of rapid decision-making, and then a course of goal clarification, and where you could have early death or prolonged survival based on kind of goals of care and ultimate treatment decisions. That's a good way of thinking about it. And then there's a growing number of web-based tools, and you can develop prognostic indices, all of them imperfect, all of them not used for clinical decision-making. You should never use for individual, but it gives you that comparison class of where you should probably start. And, you know, there's not a lot out there on neurologic disease yet, but certainly this is one, Prognosis, if you've never been to it. It's pretty impressive. You can just go on here. You can actually, for the more generalists, you can go in and actually get kind of comparison class estimates of function and mortality for various disease groups with cancer and without cancer. And these are growing. And so then you move from the external view to the internal view. You tailor your, and this is what, like I said, this is what the super forecasters do. They start with the external and then they tailor, modifying up and down their predictions. And here we consider patient-specific factor, those signs and symptoms, comorbidities, attitudes, and you adjust your prognosis up or down. You focus on the outcomes that are most important to patients, And what I say here is you be a dragonfly and seek out opinions of others. And what I mean by being a dragonfly is you multiple eyes are moving in different directions, and you can actually take those perspectives and then unify them into a integrated, whole. But, you recognize your complexity in the actual environment around you, and you have to integrate that into the whole, bringing in all that information if it includes seeking out the individual. And then the other characteristic of a super forecaster is they're belief updaters. They update prognosis when new information is available. And so you tailor your information. You're constantly looking at multiple perspectives. They call it a fox. That is, you actually are looking and seeking, and you're constantly looking and melding new information, as opposed to what they call hedgehogs, who kind of are stuck on one big idea, who are big idea generators, but they have less ability to be open-minded and flex into other areas that may help with kind of assimilated information for the prognosis in the future. And so this is Bill Flack. These are the characteristics of a super forecaster, who actually literally were 30 to 40% better in predicting geopolitical events than the CIA themselves, interestingly enough. They have dragonfly eyes, which I just mentioned. They are good Bayesian updaters. You don't have to remember the Bayesian equation, but they think in terms of probabilities. They actually are not afraid to stick a probability in their estimate. And when the facts change, I change my mind, as I think Winston Churchill said. This is what they do. They're not hedgehogs and stick to that one idea. As I mentioned, they use comparison classes, and they adopt the outside view first, and then they go to the inside view. They recognize the legitimacy of competing perspectives and qualify their arguments with a lot of buts, althoughs, and howevers. They actually can they're not very charismatic, because they kind of say something and then they go, well, on the other hand, or well, but this may be still but they do that, and they kind of recognize these competing perspectives and then internalize them. And the other thing they do is, which is usually against what we recommend in medicine, and I'll be interested in other people's thoughts on this, is they translate vague verbiage hunches into numeric and precise probabilities. Super forecasters are the most precise prognosticators. They actually will say it's a 42% chance, and they're not afraid of doing that and being more precise than even the average forecaster. And so we think of distinct possibilities, which ranges from 20 to 80%. That's not a very good way to prognosticate and be accurate. They literally will go into increments of 9 to 10 kind of possibilities and be very precise in their estimates. And then they do postmortems on both their failures and their successes. They do what I hope to do when I have misprognosticated, and reflect on, why did I get this wrong? And they do it even on their successes, because I think most of these super forecasters are even humble enough to realize that they may have got it right, but they were just lucky. And so now that's formulating a prediction. And in some ways, I think that's probably intuitive, all of us. How that translates into the medical environment at the bedside is a little more challenging, and I'm still thinking that through. But those are the characteristics that allow you to do it well. And then communicating what to expect. And we all know the many, and actually, if you go into the Epic Neurology website, there's going to be 5 modules on communication. And one of them is serious illness communication. And they go through all of these ways of delivering bad news. And this is just one of them. This is the SPIKES protocol: setting, perception, initiation, knowledge, emotion, and summarize. And then really communicating what to expect is only focusing on the one area, communicating knowledge. And what is the way to communicate that prognosis to patients in a way that allows them to best understand it? And I won't go through these in any great detail, but there are recommendations to do this. We all have developed our own techniques, the caveat, ballpark, exceptions, the best case, worst case, most likely, to try to give people a range and convey that uncertainty, and to emphasize both the positive and the negative framing, so people get a good perspective of it as they try to negotiate the decision. I won't go through these. They're on my slides. I'm happy to share them with you, but this is a caveat, ballpark, exception when you're trying to do a survival estimate with a patient who wants to know how long you think they may have to survive. And I don't shy away from that if people want to discuss that. And sometimes I'll even ask their permission if it's okay if they want that information. And then we have the best case, worst case, and most likely. Again, to give a way, this is the words and the phrases that you kind of can practice to try to do this. And I don't know, maybe in your programs you have role playing that you can practice these, which I think can be helpful, and people can gain skills in doing this more effectively. And so those are the skill sets and some of the tools and tricks to be a super forecaster and formulate a prediction. How do you do it well? And then in communicating that, and then just it's mindful to be aware of biases and developing radical awareness of them. We know of these with Tversky and Kahneman and Think Fast and Slow. But this quote I liked: providers can be well-intentioned, honorable, dedicated, have no idea bias is affecting care. It can have devastating effects on healthcare. I'll just focus a bit on each of these. Optimism bias, affective forecasting, morphocalism, and then withdrawal of treatment bias. And then obviously the internal and systemic bias that comes with racism and its tremendous impact on prognosis in all of its forms, from the internal, internalized, institutional, and system. And we all know the disparities in healthcare and how that impacts prognosis greatly. This is how well do physicians predict survival in advanced cancer. We know that if you ask, physicians are correlated. But they are often not accurate because they're overestimating survival by about 30% in this study, now over 20 years old, but this has been shown time and time again. The estimates of survival get better, more accurate, the shorter time the survival is. So that's a horizon effect. And actually Phil Tetlock would say that with his super forecasters. The horizon makes a huge difference how accurate you are. And then the other one is, I think, also intuitive. It's the relationship duration effect. If you have a relationship with the patient, you tend to be overly optimistic because I think we are more connected with them emotionally and we are hoping for that optimism. This is where the optimism bias comes in as well. And then the other is affective forecasting. This is another cognitive bias. And I actually think this is a tenacious, a tenacious bias that is hard to overcome. And this is, do you misimagine the unimaginable? Many of you may have seen this in the health psychology literature, is that we tend to not predict our future health states accurately compared to patients themselves. And so we non-patients tend to, if these are patients who have a colostomy on dialysis, who are paraplegic, who have severe stroke, they may tend to rate their lives at a scale of 0 to 1 on this range. But if you ask non-patients, including physicians, what would you expect them to do? Because they haven't had experience in those events, we tend to overweight the impact that those health states would have on us. So that future forecasting, it's predicting a future health state, a future affect, that we overestimate the impact. So we actually value health states less. So we overestimate the impact it will have in patients and families, and actually rate their health states better than physicians or non-patients do. And that's been called the disability paradox in affective forecasting, or the focusing illusion, which is you tend to focus on only the negatives, the bag, the colostomy bag, for example. You don't think about all those other billion things patients can and families can adapt to and find new meaning in life. And it is, people equilibrate over time. But it's a good question to ask, what's the impact that may have on decision-making in the current, when we're thinking about the future events at the bedside. And then this is another one that kind of we wrote on and thought about, but this is an example of getting the right comparison class. So here's an instance, what we call the withdrawal of treatment bias, and in that severe acute brain injury example, short-term mortality may be influenced by early treatment decisions, as we just discussed. And we just need to be cautious about using published short-term mortality models, as they may overestimate mortality by up to 50%. Again, it's the wrong comparison class to use all patients in these published mortalities, because they actually include those patients where treatment may have been withdrawal based on goals of care discussions. But if you ask the question, what would be their life expectancy or survival if all therapy were given early on, that's a different group. That's a different comparison class. And actually, it can be as high as 50%, because 50%, up to 50% of short-term mortality actually is because of withdrawal of treatments early on. And then there are new models. That's why I say be aware of this comparison class. And if you're going to literature to find that kind of comparison class to start anchoring your kind of estimate, you need to be mindful that use the right comparison class and then individualize and tailor it based on the patient characteristics. And then there are new models that are accounting for this confounding. They're called the MAX ICH. It was published in Annals of Neurology last year. And then there are just strategies and ways to minimize the biases here. Force yourself to think and communicate the lower bound of the estimate. Know it exists and think of many ways to find joy. Be cautious about the published short term and adjust downward. So you got to be mindful of all these just to make sure. And then we're all on this journey about learning of the impact of longstanding biases, both systemic and internalized, in their impacts. And in fact, that's I don't mean to minimize. I mean, that it deserves a whole course in itself. But in fact, I include it just because it's such a profound impact that we're all still understanding and finding, and how that interweaves with all these other cognitive biases that, you know, and one of the questions is how entrenched are these cognitive biases? You know, Phil Tetlock and his group would say that you can train people to overcome some of these biases, but some of them you can't. Some of these are really tenacious and they are hard to overcome. Like when you know, even when you tell a patient has got, you know, advanced cancer, their life expectancy, and you tell them what their life expectancy based on your best estimate is, they still don't believe you. They still think it's 1 or 2 years longer than they, you know, despite that. And we know how intransigent, you know, how important that is. So let's just finish here by talking a little bit about understanding and managing prognostic discordance. And this is important because we all have talked with patients and we're not connecting. And we're not kind of seeing eye to eye. Well, what does that really mean when we're not kind of feeling we're making a good connection with our shared decision-making or kind of our discussions with our patients and families? And these are 2 quotes. I need to be more optimistic for her. Doctors don't see family support. Her family being here for her is going to help her. And I'm hoping, putting faith in what could be and staying positive. And these are 2 quotes from the study I'm going to talk about now that tries to get at prognostic discordance in patients who present to a hospital with severe acute brain injury. And this, but before I do that, I just want to kind of, even though I can't see a show of hands, what percent of surrogates rely exclusively on your estimates of prognosis? Is it 2%, 10, 25, 50, or 75? Well, interestingly enough, it's actually been studied, and only about less than 2% of surrogates relied exclusively on physician information. Other factors include the perception of patient strength, character, and will to live. It's kind of their own internal assessment of what embodies prognosis for their loved one. And so they supersede your estimates or use your estimates in their own estimate, involving these other factors. And in some ways, we shouldn't be surprised by this. I think 10 years ago when this study was published, there was a lot of surprise by this. But as we see how science and medicine are kind of combining with, you know, our communities at large, there's much more information put on other factors when people formulate their own opinions. And they do so here. So prognostic discord, this is when clinicians and patients and families differ in their perspectives on prognosis. And in critical care literature, rates of prognostic discordance range from 50 to 61%. And actually, it's highest in those patients with severe acute brain injury when it's been studied. Whether or not that's real or due to study-related factors, we don't know yet. Now, think about that discord. And I'll just say it could be due to several different things. It could be due to just a misunderstanding based on non-understanding the facts, or it can be due to belief differences. And regardless, they can understand all the facts, but they still are tenacious and they just want to believe differently, or they just believe differently. And then knowledge of the cause can inform how to address. So this was the study we looked at. This is Dr. Kiker and Claire Kreutzfeld. They're from WashU, University of Washington in Seattle. And they published this this last year in September in JAMA Network Open. And they just looked at about 200 patients, Glasgow coma of 12 or less on day 3. They asked loved ones and physicians, and they patients who had severe acute brain injury, so hypoxic ischemic encephalopathy, severe stroke, or TBI. And they just asked this simple question: looking at 6 months or so from now, what do you think your patient's or loved one chance is of recovering to a point of independence or better? And there were physician predictions and family predictions. And they just kind of averaged out, and they put the averages here. And they defined prognostic discordance as a 20% or more difference between the two groups, the physician prediction and the family prediction. As you can see here, the average prediction for the physician for this group of 200 patients was about 32%, 33%. So 33, the physicians predicted that about 33% would actually, at 6 months, be at a point of independence or better. The families felt that the average was about 53%. So the average was about 20% difference. But the actual number of patients, the single patients of prognostic discordance of 20% or more was 61% of those pairs. There was 111 out of 160 patients. There was a 20% or more greater difference between the family prediction, which was overestimated, versus the physician prediction, which was less. Then they asked another question. They actually had the family estimate of the physician prognosis. And they asked, if you had to guess, what do you think the doctor thinks is the chance of recovering to independence? So they asked the family. And then they actually, which I thought was, it was a good question to ask, because then they could actually say the difference between the physician and the family estimate of prognosis would be a misunderstanding. And actually the family estimates of the physician prognosis and their own prognosis. And if there was a difference here, that would just be an optimistic belief difference, suggesting that, regardless of what the physician says, I just believe the prognosis is different. We all have seen that. And the question is, it's probably a really important and necessary, sometimes, hope to manage with patients. And in this study, there was 46% of the participants that had actually misunderstanding, and over 50% had optimistic belief differences. And so the majority of the family, there's a misunderstanding. And so this prognostic discordance is actually, if you think of it, it's caused by a combination of both misunderstanding and this belief difference that we got to kind of think through and think about how best to address. We looked at associations with the types of discordance, and prognostic discordance was greater when the family member, and it was in a minoritized racial group, and the odds was 3.14 more likely to have prognostic discordance, or if a family member identified as a sibling and adult compared to a spouse, there was more prognostic discordance. We also asked nurses their perception of family understanding as well. And so nurse perception of fair or worse family understanding was associated with family understanding. But we also asked the physicians. The physician perception of fair or worse family understanding was not associated with family misunderstanding. So it raises this possibility that those nurses at the bedside actually may be more in tune to identifying true family and misunderstanding compared to physicians who are maybe not so much at the bedside, kind of hearing the background discussions that occur and how they're interacting with the nurses and other care team members while they're in the room. So what are the key takeaways? And I'll have the five or 6 minutes to, just answer questions. Is prognosticating is obviously central to neurology, I would say broadly, and is the foundation of the biopsychosocial home in neurology. Rochester's the home of the biopsychosocial medicine, and it's George Engel wrote about that back in 1977 in Science. Developing the right mindset, tools, and skills can improve one's ability to formulate and communicate a prognosis, including kind of some of the skills and mindsets to think about being a super forecaster, as well as trying to communicate that prognosis to improve decision-making. In prognosticating is subject to many biases, which can dramatically affect your care. It is important to recognize and reduce them. Recognizing that some are more tenacious than others, and our educational efforts won't be able to eliminate probably all of them. And we probably don't want to eliminate all of them, but we have to recognize that some of them are probably essential to maintaining hope. And we have to develop the skills to managing multiple hopes at once with our patients and developing skills to address that. And then patients often, and surrogates often do not hear what you tell them. And even when they hear you correctly, they form their own opinions. So I will stop there and conclude with another quote by the Yogi Berra, that predictions are difficult, especially about the future. This is tough stuff, but for me, it's kind of fun to think about because it can only help our patients' care. And I don't think it's received a lot of attention. So I'll open it up to questions, and I really thank you for your time.
Thank you, Dr. Holloway. So anyone in the audience, we had the microphone open, and then there's no question. We can go maybe in the chat if you want to ask over there as well. Dr. Francisca, you want to ask a question? You need to open the microphone.
Oops, looks like you're muted.
Let's see, Dr. Francisca?
Yeah. Oh, he's on an iPhone, so he may not be able to chat it easily. You're still muted.
Okay.
Yeah, I have a question. This is Nick Pamitsakis. Thank you very much for your nice talk. And I was impressed, obviously, by these super prognostications caters, like the gentleman that is better than the CIA you mentioned.
Bill
But
Flack.
I wonder, yes, but I wonder, I mean, if that's feasible for us. I'm a stroke neurologist, and if I have a patient with a stroke or a patient in the ICU with a bleed and a severe current condition, it's hard to give exact numbers. And this 32% or whatever percentage, I don't think it's easy to get from, at least from the let's say the papers that we have describing potential outcomes in these patients. And I just want also to mention that, for example, let's say the ICH score for patients with intracerebral hemorrhage has been kind of criticized because maybe everybody who does, calculate a score based on this can get a number there, and in the higher scores it approaches, let's say, mortality of, let's say, 99%. And maybe it becomes a self-fulfilling prophecy in some of these patients to, to abandon, let's say, the efforts that we can put, at least for the beginning of their hospitalization or of their care, instead of, giving them some more chance and observing them a little bit, more before we commit to this particular, prognosis.
Yeah. So I agree with you. In fact, I know over the last 6 months, I just read Super Forecasters myself for the first time. And it was a fascinating read for those of you who are interested in this topic, because it does counter some of the counsel we've given, and I've actually given through the years, and I'm very well aware of the stroke literature of all you mentioned. But I guess it just challenges us to say, if our goal is to try to be as accurate in projecting predictions, it probably does, we have to probably think numerically and more precise, but then separating that out and saying, well, still, what's the right way to communicate with families at the bedside, which may not, we're not pundits on the airwaves talking about political predictions, and where we can say distinct possibility, which can mean anything and kind of saves us if we need to, if we're wrong. But I do think that we need to give that some additional thought on how best we conceptualize our ability to prognosticate. I'm not advocating for doing numeric probabilities to the patients, but you know what? I actually think, my experience over the years has been, if it sometimes doesn't feel right, it's probably the right thing to be thinking about studying, because it counters kind of the standard way of thinking. And, how do we challenge ourselves to do better? So I don't know. I actually am thinking, how do we, I want to talk to Phil Tetlock and ask him, how do we study medicine? And how do we study severe stroke patients and prognostication? And how do we adapt your model and super forecasting for the CIA to the medical environment? I'll be fascinated if people have ideas about that, but we're running out of time. If we have time for one or two more questions, I'll be happy to take them. Oh, he just unmuted again.
Hi, Dr. Holloway. This is Srinivas, one of the resident. Thanks for the nice presentation and the talk. I have a question, like anytime you compare the surrogate expectations of the prognosis with the patient expectations of the prognosis, who can talk? Like we can, patients who can have a, make a decision. Yeah.
Yeah, I haven't dug as deep into the cancer literature where there may be some information about the differences between patients themselves and surrogates. I know there's a healthy literature in cancer on patients' own perception of prognosis, and they always overestimate their survival compared to what physicians tell them, and they remain overestimated even when they're given their life expectancy information. So even when you educate them and you re-ask them, as I said, I call it tenacious. They're still tenacious in their optimistic beliefs. And I don't think that's a bad thing. I think we just have to learn how to manage that. So, but I don't know the literature of the literature. I know that surrogates don't often agree, and that surrogates don't often agree with patients. And Adam Kelly here in Rochester's done some prior research looking at the agreement between patients and physicians on health states, which is not very accurate.
Thank you.
Yes, the anti-vax movement and its success in this country, the United States is among the worst death rates and lack of vaccination compared to other first world countries, including most of Europe. There's been extensive education, extensive communication, and yet this massive failure continues. Could you comment on why something like this could happen? Because not only are the people putting themselves at risk, they're putting others at risk.
Yeah. Well, I don't know. I can't. I'm not. But there's something about these where cognitive biases turn into kind of perceptual illusions, and they become delusions, almost fixed false beliefs, and they're not going to be treatable by your basic explanations and educations or your appeals to anything. And there are certain cognitive biases that are really resistant to change, despite we think of that perceptual illusion where you have the line and the arrow at the end, and you put a ruler up to it, and then, guaranteed every time you put your ruler up, and if the arrow is pointing out or in, I guarantee if you challenge yourself to do that, you probably have seen that, you put your ruler up and they're the same. And then you take your ruler away and you'll be darned. They just look as far apart as they did the first time. But that's a symbol of how you have a fixed false belief in your brain. And somehow this anti-vaxxers, and I think some of the things that's going on here are some of these cognitive heuristics that are really entrenched in our way of thinking. And I think that's one example. And I think there's going to be many examples in the way we think about our health and disease that kind of react the same way. So I guess I don't know the answer to that, but I actually think there are many similarities of what you're talking about, and how do we think about some of the biases when we're confronting patients and trying to work with them, acknowledging them, and then how do we approach them in management of either training ourselves or trying to teach them, and what are the limits to that. So I wish I had answers. You know, as I said, this is not I'm not a cognitive psychologist, but I just love this stuff because it impacts our care so greatly.
Okay, I think I'm gonna go with last question from the chat, from Dr. Spart. Many of our patients use religion to cope with life.
Wait, can you start over again, Sergio?
Yes, I'm gonna say, so many of our patients use religion to cope with life. How do you integrate this fact into your approach?
Oh. Yeah, well, you know, I think trying to be as culturally, trying to have as much humble curiosity and knowledge as I can. You know, having a growth mindset, trying to learn about all religions as best I can and how that impacts people's views of their own lives and approach to medical care, and then incorporating that into, but you know, religion is a kind of a big belief, and that actually people find a comfort in that. And so, I mean, it's being sensitive to understanding, having a humble curiosity, that palliative care mindset of humble curiosity, learning and integrating that in, but knowing that there are going to be associations between religiosity and optimistic belief differences, and all of those associations are going to play themselves out in terms of, and people find meaning and value and hope in that. So how do you cultivate that while at the same time being realistic? Some of those two things can be at odds with one another. And so you have to kind of, managing multiple hopes is one of the great challenges and great honors of our profession. And, you know, we have to try to do both.
Dr. Holloway, I think we're gonna close for today. I think that it's been a wonderful lecture. I think there's also many questions that also from the participants. I think that you're very like a person that is very approachable. So I think like at any time, I think.
Well, like I said, I'm honored to see you all and be with you today. And I look forward to seeing some of you as well. And say hello to Steve if he's out there, Steve Levine, and many of the others.
Perfect. I will do.
Okay, take care.